So now we're going to talk about some different types of intracranial hematomas that 2-year-old male with a history of a cerebrovascular event and seizures who presented with progressive altered mental status per the family. So on his exam, again, we get back to that GCS, the Glasgow Coma Scale. He's a 13, so his motor is 6, verbal is 3, and his eyes are open. So he's following commands, and he's talking, but he's not making much sense, and his eyes are open. He's awake, alert, oriented to name only. His pupils are equal reaction to light. His ectopic movements are intact. What we say his face is equal, and he has a left hemiparesis with a drift. And so hemiparesis with the drift is where the left side of his body is not working with full strength, and a drift is where you have a patient hold their arms up in front of them like they're holding a very large pizza pan and close their eyes. If you have subtle weakness related to an intracranial problem, what will happen is that their hand will start to pronate unbeknownst to the patient. And so that's how we test for subtle weakness in patients like that. And this is his CAT scan on admission. So what we see here is a CAT scan, the axial on the left, a coronal on the right. And again, remember what we talked about CAT scans is that dense things are bright and things that are not dense are dark. And so in the middle of the brain, we see the ventricles that are essentially water. They're very dark. Then on the outside, we see the skull, which is very bright white. And then there's this fluid in between the brain and the skull. The biggest of it's on the left. That's called a chronic subdural hematoma. So it's a collection of fluid, blood products that have developed in that potential space between the dura and the arachnoid. Remember from your anatomy that is not a true space, but what we call a potential space, and there are bridging arachnoid adhesions between the arachnoid and the dura, and that's called the subdural space. And so that patient was treated surgically, where we took him for what we call a burr hole, is where we make a small opening within the skull, and we drain that fluid and allow that brain to re-expand and fill that space. And so now you see it is much darker, and so it's filled with air. So versus being filled with fluid the first time, it's now filled with air. And so now we have a 23-year-old male with renal failure on dialysis who had a car wreck. He called his father after the wreck and said that his knee hurt. And his father took him to an outside hospital emergency room and felt that the patient was fine. They discharged the patient. He was on his way home, and father noted that he became less responsive but was still awake. He brought him to UMC, and he had a GCS of 13. So his motor was 6, his verbal was 5, and his eyes were 2. So that means that he's laying in bed, he follows commands, he's oriented, but he keeps his eyes closed unless you really stimulate him hard. He's lying in bed with his eyes closed, he's lethargic, but he's oriented to person, place, and date, and he's moving all of his extremities. So he gets a CAT scan. This is a coronal view of the CAT scan that was taken at the outside hospital, and it shows a very hyperdense area between the brain and the skull, pushing on the brain, and the patient was transferred to UMC. And acute blood looks dense. It's because it is congealed. There's lots of hemoglobin, and so it is it's dense material, much denser than spinal fluid, but less dense than skull, obviously. And he was transferred to University of Mississippi Medical Center, where a repeat head CT shows now a much larger hyperdensity pushing on the brain with much more brain compression and now all of these smaller areas of hypodensity inside this pocket of blood. And so hyperacute blood, active bleeding, looks hypodense. And so it is this sort of paradoxical thing where there's hyperacute blood looks hypodense, acute blood, meaning blood that has, so hyperacute is blood that's actively bleeding. Acute blood is blood that is has bled but has just been present for just a few hours, or at most, a day. And then there's subacute blood, and then chronic. And then chronic becomes more hypodense and looks like water. And so we see his initial CAT scan from the outside hospital compared to the CAT scan at UMC, showing a massive expansion. And this is what we call an epidural hematoma. And it's epidural and has this very characteristic lenticular shape, and it has this very characteristic clinical story where someone is in some accident, they hit their head, and then they have what we call the lucid interval, where they appear to be fine, and then all of a sudden they become rapidly less responsive and can herniate. This is a medical emergency because that bleeding is arterial blood, and it is rapidly expanding, and if you don't stop the bleeding, then that patient will succumb to that mass effect. Remember that Monroe-Kelly doctrine, to where there's now mass inside the brain, but because it's happening quickly, because it's arterial blood, there's no ability for the brain to compensate and move something else out. So it doesn't have the time to move spinal fluid, doesn't have the time to move blood. It's expanding quickly, and so the pressure goes up very rapidly. This is a medical emergency, and we took this individual for an emergent craniotomy for evacuation and stopping of the bleeding, and he did very well.